Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to you all to the first lecture of a series of a lecture organized by Oman Transplantation Society. I'm Dr. Luar Al-Hashmi, a consultant liver transplant and hepatobiliary surgeon in Royal Hospital and a member of Oman Transplantation Society. So actually this is the first lecture, and on behalf of all members of our Oman Organ Transplantation Society, we welcome Dr. Mustafa Al-Mousawi, who is actually the president of Kuwait Transplantation Society, and he is a consultant and chairman of Kuwait Organ Transplantation Center and the Council Centers of TTS, representing the Middle East and Africa. Dr. Al-Mousawi has established the organ procurement from deceased donor in Kuwait, which is actually among the top 4 countries in the Middle East in this field. He was the steering committee leading to the Declaration of Istanbul, and he was the co-chair of the Patients Affairs Committee of DICG and member of Ethics Committee of TTS. He was also the president of the Middle East Society for Organ Transplantation. Welcome, Dr. Mustafa. And Dr. Mustafa will talk about the Kuwait experience of establishing a disease organ transplantation. Welcome, Dr. Mustafa.
Thank you very much. And I would like to welcome all the participants in this talk. I hope I can give a picture of our experience, or a glimpse of our experience in Kuwait and organ procurement, which started in 1996, and it is still growing, alhamdulillah. So I really feel at home when I talk to people in Oman. I'm trying to, yes. I've been to Oman twice at least, once on the invitation of Professor Dar many years ago, and another time when the MESOT Congress was held in Oman. And I think Dr. Nabil Lawati had a great deal to do with that Congress, and he worked very hard together with Dr. Faisal Shaheen in holding the Congress. So I'm very happy. And also, of course, we have Dr. Kadhim, who studied in Kuwait, and he is well known, and he was a favorite even when he was in Kuwait. He was one of the most clever students that we had in the Faculty of Medicine, and now he is back in Oman and is doing a very good job. And my regards to him, to all my friends there. So basically, we started a program for deceased donation in 1996. Of course, transplantation program started before that, but the actual starting of the deceased donor program came in 1996, and since then it has been progressing. But always we had more living donors than deceased, and I think this is normal in most of the Middle East countries. There is more living donors than deceased, not only in the Middle East but in the whole of Asia as well. But if you can notice that in the last few years, we have really narrowed the gap between the deceased and living donor kidney transplantation. In fact, 2019, we had almost the same numbers, 53 compared to 50, which was a very good, nice achievement. Although the next year, because of COVID, everything came down, and this year we haven't managed to get to the same level, but we are trying our best, and we hope that in the next few years we can have more deceased donors than living donors for kidney transplantation. And if we look at our achievement in the region, these are the transplant data from Transplant Observatory, which is related or belongs to WHO. And you can see that Iran comes in the number 1 in this respect. This is 2019, followed by Kuwait, then Saudi Arabia, Qatar, United Arab Emirates, then Morocco. This is Eastern Mediterranean region. In 2020, the figures are more or less the same. So is it is it a magic, or is it very difficult to establish a deceased donation program? I think it is not difficult at all. What you need is to start. So you need to decide to establish a program. And I think you have made up your mind in Oman to establish such a program. Although such a program did exist in Oman in the past, because I remember the smallest child in the world, or the smallest donor in the world, came from Oman. It was done by Professor Abdullah Dar many years ago, who transplanted a small kidney from a very small child, I think in the neonatal age, to another child. And this was made a big sort of headlines all over the world. I think you should start with a course, and there are many courses. TPM course, which is the Spanish group, which is Transplant Procurement Management course, is the most famous in the world. They hold congresses, they hold courses all over the world, and they have held many courses in the Middle East as well. Is that a best course? I'm not sure, because I think our situation differs from Europe. So what applies in Europe doesn't apply in this part of the world. We should develop our own TPM courses which are related to the region we live in, because the way we approach the population of the region is completely different from European population. Acceptance of brain death, acceptance of donation cultures, all differs, To start with, I think you should involve ICU staff. I'm very glad that many of the ICU staff, nurses, and doctors are attending this talk. And you have to get them involved, because without involvement, without cooperation by the ICU staff, you will get nowhere. You should also involve the hospital administrators, and the ministry. They should know that you are doing a good job, because you are getting organs for people who will be dead if they don't get these organs. I mean, they will either stay on dialysis if they have the renal failure, but when it comes to other organs like the liver and like the heart and so on, you are saving their lives. And then I think you should appoint a transplant coordinator or coordinators, and then you have to train these coordinators. And finally, should you educate the public or hospital staff? Now, both are important, both are necessary, both are needed. But to me, for me, educating the public is very tedious, very costly, and takes many, many years. So concentrate on educating hospital staff. These are the most important people. If you want your program to rise from zero, concentrate on hospital staff, leave public education to later on. Now, of course, Kuwait is part of the GCC countries, and there is a lot of similarities between Kuwait and Oman. And for example, the population is more or less the same, 4.6 and 4.4. I think these are figures maybe changing every year, but we have roughly the same population. And in both countries, we have the citizens and we have expats working in the country. In Kuwait, we have only one transplant center and multiple dialysis centers. I don't know how many we have on dialysis. The nephrologists don't tell us, but I guess there are more than 2,000 on dialysis, and the numbers keep increasing. The number of dialysis centers keep growing. Many patients, they don't get the chance to be on dialysis. They leave the country if they are expats. So it is really a big problem. And we have only one kidney transplant center. We have also one liver transplant center, which was active but became inactive after COVID, because the hospital was used basically for admission of most COVID cases. But we are planning that maybe early next year, if situation is under control for COVID, to start the liver program once again next January or in the next couple of months. The service is a public sector. It is not private. It is owned by the Ministry of Health. Everything is provided by the Ministry of Health. No private doctors, no private patients. It is a public service. Transplantation is a free service for all residents of Kuwait, Kuwaitis and non-Kuwaitis, which is great, because 2/3 of the population are non-Kuwaitis. In fact, most of our donors come from non-Kuwaitis. So it is good to provide them a service in return for their service in donating organs. Deceased organ program, I said, started 1996, and the organs are allocated not only to Kuwaitis, but also to all residents of Kuwait free of charge. So residents of Kuwait, they donate organs and they receive organs without any charges for the operation, for the follow-up, and so on. Now, just a glimpse of the history. The transplantation program in Kuwait started in 1979 in February. It was living and deceased donor program. Professor Abuna, he did the first pancreas transplant from a living donor in Kuwait, and he attempted to do a deceased donor liver transplant in 1989. Unfortunately, that wasn't successful. And then, of course, the invasion came and the whole program came to a stop. We had some deceased donor kidneys, which were important from outside the country. Professor Abuna accepted these kidneys from Europe and from the United States. These were the kidneys, I'll discuss it in a minute, the kidneys nobody wanted. So they had long cold ischemia time and the results were extremely poor. This is the first patient who was transplanted, and the donor was his brother. And all the efforts in starting transplantation were due to the late Minister of Health, Dr. Abdurrahman Al-Awadi, who was really the force behind establishing the program. And he was also the president of Kuwait Transplant Society until a few years ago. We lost him only a few years ago, and he, as I said, he was a really great figure and as a Minister of Health and as input for transplantation. Now, the first transplant, it happened in the region. It happened in Iran in 1968. In the 70s, many other countries started to do kidney transplantation. Among them was Kuwait, which started in 1979, and Saudi Arabia in the same year, a few months after us. And then, of course, other countries started their program, UAE, Qatar, Oman, Algeria, Morocco, and finally other countries followed suit. So the source of the kidneys for transplantation, when the program started in 1979 until it came to a stop with the invasion, Iraqi invasion of Kuwait in 1990, there were three sources: living donors, like imported deceased donors, these are the kidneys which were imported from Europe or the United States, and local deceased donors. There were few local deceased donors, but there was no regular program. There were two cases in 1983, one case in 1987, one donor, and there were three donors in 1989, and a couple of donors in 1990. And then, of course, the program came to a halt. So if you take the number of kidneys procured, locally in Kuwait, the numbers were very small and didn't contribute more than less than 4% of the transplanted kidneys. Now, first deceased donor transplant was in Jordan, believe it or not. Although Jordan now is not very active in deceased donation, the first transplant was in 1972 from a deceased donor. Then other countries in the same year or in the 70s, Turkey started. But most of the countries in the 90s and after the 90s in different countries, and Iran, which was the first country for living, they started in 91. In Kuwait, we did the first deceased donor in 1981, Bahrain 2001, Qatar, UAE, and so on. And in Oman, I think the first one was 1998. Now, a couple of words about imported kidneys. These were kidneys nobody wanted. These were kidneys which were bad kidneys. They were either very, small kidneys, pediatric kidneys, or they had injuries like ureteric injuries or multiple vessels, and various injuries which happened to the kidneys. And since they were offered to centers in Europe or the United States, they were not accepted. George Abuna accepted them, and he transplanted quite a number of these. But unfortunately, the short and long-term survival of these organs, of these kidneys, were very poor, less than 40% in 5 years. So it was very bad. In June '81, there was the first kidney from Eurotransplant, and in the same year, in December, a kidney came from the United States. Just imagine the how to get a kidney from the United States. It was brought by Concorde to London, and then by an air taxi to Bahrain, and from Bahrain it was shifted to Kuwait. And it cost a lot of money for very poor kidneys. We started the program again towards the end of '93, in November '93, the program which was stopped because of the invasion of Kuwait, and then gradually the program has grown much larger than in the previous period. And also these red columns show the number of deceased donor kidney transplantation, which is now contributing to around 40% of all our kidney transplants, and some of the some of the years it reaches nearly 50%. How did we start? We started with the transplantation coordinator course, which with the help of Eurotransplant people. This is Celia Waite and her colleagues who came. We held a course. This is me when I was a little bit older than now. And also we had, of course, we had participants from different Gulf countries. We invited them to attend the course. There were people from Oman. This is Dr. Busaidi from Oman, and I think we had a nurse as well, but I'm not really sure. I cannot remember. And we had Saudi coordinators who participated. And these are, most of them are nurses and doctors from the ICU. These are all intensivists and anesthetists. And this was the undersecretary of the Ministry of Health. So we started in '95, and then we relied on the Kuwait transplant law, which backs to 1987. And the law, in fact, we had a law before that, which was 1983, and that law is only basically for kidney transplantation. And then a law appeared in 1987, which is for organ transplantation. And in this case, the law allowed to take organs from deceased, and then the deceased was documented as deceased by a committee of three doctors. One of them should be a neurospecialist. So we had a law which we relied on in starting the program. And then the transplant law basically says for living donors, no selling or buying of organs. For deceased donor, death determined by a committee. Minister of Health can give consent if relatives are not available. This is a section in the law which allows the Minister of Health to give the consent if no relatives are available in Kuwait or could not be reached abroad. We had also religious fatwa, which was since 1986. This is Qarar Majlis al-Fiqh al-Islami, the Council of Islamic Fiqh meeting in 1986 in Amman, Jordan, which was attended by doctors and religious leaders. And they say death can be by two ways, either irreversible cardiorespiratory arrest or irreversible brain death. So brain death, when the brain or brain stem and brain function is completely lost irreversibly, then he can be considered to be dead according to the Islamic Sharia. And you can switch off the ventilator even if the heart is beating because of the machines. So we had a law, we had also a fatwa, and then we had several ministerial decrees which regulated how we act. This decree, we write it and we give it to the ministry to sign it. And this is what I did in 2002. And we made it compulsory to refer all potential donors by ICU staff. So it is not like I like to refer this case or not refer. It is compulsory. Every potential case should be referred. And COP, which is Kuwait Organ Procurement staff, will follow all potential cases and approach the family for donation. Family approach should not be done by ICU staff because that would be a conflict of interest. It should be only done by the coordinators who are expert in approach, okay? The timing of death is very important. It should be the same time as brain death diagnosis. If you believe in brain death, then brain death is the actual time. And if you put the time after retrieval, somebody might come and say, well, he was alive before the retrieval. Because you took the organs, you killed him. So they might take you to court. Always, and this happened once in Kuwait, and that's why we made it compulsory to issue death certificate before retrieval. When we started, of course, we didn't have any coordinators. This was immediately after the course, and I managed to get somebody from the United States, Bobby Cumberland, who was a transplant coordinator. who came to Kuwait, and I brought him for 3 months to see if he is good enough, then we can continue with him. Unfortunately, I found that he is not suitable because he comes again from a culture different from our culture. We need somebody who can speak the language of the people, and he couldn't do that. So although he helped us in putting a lot of protocols, but then we started looking for a local coordinator, and this is Fawzi Al-Khawari, who was a nurse, and he came to us, and we trained him as a coordinator. Initially, he did very well, and then he became busy in other things and in politics and so on. So eventually, his performance wasn't that good. So we had to replace him by others. So we brought other Kuwaitis. This is one, and this is another Kuwaiti, which I took to Lebanon to attend a TPM course organized by the Spanish group, and I was with them at that time. Again, you know, we trained them, but most of them, they were not really interested. They came to become coordinators just to get rid of working as a nurse. So unfortunately, they were not really interested. And most of them, either they have to leave or I have to ask them to leave because they were not really active. We did also local training. So we started to train intensivists in the ICU. These are some of the doctors in ICU and some of the nurses, our coordinators and nurses in the ICU. So we took them to Kuwait Transplant Society, and we had a course about organ procurement. And now, over the last few years, we managed, with the help of the ministry, to appoint about 7 coordinators. This is, I think, most of them, but there are a couple which are not there. And one of the most important one is the driver, Abdul-Mu'ti. Abdul-Mu'ti does a lot of things. He takes the teams to the hospitals, and he takes the organs back. He's a very active man. And when we have organ sharing, he receives the teams which came from Saudi Arabia or elsewhere, and brings them to the hospital. So he's part of the team as well. So we have now 7 coordinators. Zainab is the team leader, and she's doing very well. And we are very organized. We have regular meetings, and we have this card provided by the ministry, and we do rounds in all the ICUs. We don't depend on ICU to refer to us. We do, this is like a mobile team. They go around to all ICUs. Kuwait is a small country, and we have only 7 major ICUs that we deal with, general hospitals. And it's easy to just go around and see most of them in a day or two. Now, if you look at the number of deceased, it keeps changing up and down depending on the activity of the coordinator. And when the activity drops, we get rid of the coordinator, bring another one. And then when he drops, then somebody else comes. But over the last few years, I must say that we are doing quite well. In 2019, we had 27 donors for a population of 4 million, which is a good number. And then, of course, the year 2020 was a COVID year. And then this year, we had 25. I doubt if you have any more by the end of the week. But this is not a good number. Should it be more than 27? Hopefully next year we have another rise. So how are we doing? We are doing relatively okay compared to our region. Kuwait is #1 among the Arab countries, and we come after Iran, Israel, Turkey, in the Middle East. But if you compare ourselves to Europe and to North America, I don't think we are doing very well. We are in the bottom of the curve. If you look at Spain, they get 50 donors per year, which is great. So we really need to come to an average in Europe. We need to reach around 20 per million so that we can say we have a very good program. The Iranians managed to get to around 12 or even I think 13 now. This is 2019. Last year, I think they had about 13, 12 point something. So they are doing better than anybody else in the Middle East. So how do we reach self-sufficiency? And when we talk about self-sufficiency in deceased donors, I hope that once we reach self-sufficiency, so we don't take organs from any living donor. Because whatever you say, donation can affect the donor, sometimes in the short term and sometimes in the long term. So deceased donation is very important. We need the support and cooperation of the government. You should really get the attention of the government. This is extremely important to save lives and to save money to the government as well. Because when you have organs available and transplant them, then you save a lot of money from sending patients abroad to have a transplant, or bringing teams from abroad to do the transplant for you. You need, of course, the hospital to support you. So you have to keep them all pleased. You need legislation, but sometimes you can, in Saudi Arabia, they don't have legislation, but they have regulation. So you need legislation or regulation, but legislation will cover you if there is any problem or any cases in the court. You need organization. This is the most important part, to organize yourself so that you became effective. And you need, for that, you need organ procurement, organization, coordinators, training, and then you need incentives. Incentives, I'll talk about it later on. It's incentives for the hospital staff and incentives for donor families. And of course, public education should be done by the government. Now, organization, we need proper establishment of OPO, staffing, training, protocols, train and educate the ICU staff. This is very, very important. We should repeat this training, more than once a year. You have to also educate other hospital staff, not only ICU staff. And you should give incentives to the ICU staff who spend more time looking after deceased donors, maintaining them. Sometimes they are difficult to maintain. So you have to recognize their and try to incentivize them. The government, if you get any support from the government, it should be through regulation and protocols. It should coordinate with other ministries and foreign embassies, because if you are like Kuwait, you have a large number of expats, then you need to deal with embassies. You need a budget. Budget is very important. Unfortunately, we don't have a budget only for organ procurement, but we have an organ transplant department, and there is a budget. We are using that budget for our activities. You should honor donor families so that encourage people, and of course, public education by the government. In Kuwait, we have Kuwait Transplant Society, which is supposed to be non-governmental, but it is, partially governmental, because we get our budget from the Ministry of Social Affairs. Not much, but maybe enough to cover the cost of the rent, of the electricity and the people who work in the society. And we depend on donation from companies and from individuals for our activities. We have this calendar which is distributed all over Kuwait in all hospitals, all polyclinics. This is 2022 calendar which has been distributed over the last couple of months. We distribute donor cards, and we also educate the hospital staff. We educate the public. We go to the mosque, we go to the schools, and try to educate the young people and the public about organ donation. And when it comes to expats, of course, Kuwait has a large number of expats, not as large as UAE, but 70% of the Kuwait population are expats. You have much less, you have 44%. And because of that, we go to the expat community. So we go to the churches, we go to the temples, and we go to the activities of the expat community and try to donate, to try to propagate or try to advocate organ donation, not only to encourage them to carry donor cards, but also telling them their rights. Many of them, they don't know. If you get renal failure, you can stay in Kuwait, you can have a deceased donor transplantation on the waiting list without paying anything. So many of them, they don't know. So we have to educate them about their rights as well. Now, what is the process of organ donation? The process starts, of course, all over the world with identification. So you have to identify potential donors. This is, of course, should be done by the intensivists in the ICUs, by also the nurses, but sometimes you have to be after them so that they can identify and they can refer. So that's why we have this mobile team which goes around. They do a round with the intensivist, see all the cases. Any case of CVA, any case of trauma is considered to be a potential donor. And we look at the Glasg coma scale. We follow these cases, and then we assess them to see if they are suitable for donation. Sometimes they are not medically suitable. Sometimes they are not really, they are not brain dead if they are still reflexes and so on. Finally, of course, we have to bring the neurologist to declare brain death if there is brain death. Sometimes there isn't, sometimes it is. So once brain death is declared, then we have to really ask the intensivist to manage the donor. This is some of our problem in Kuwait, that donor management is not best in Kuwait, and we lose a lot of potential donors because of poor management, especially in the weekend, especially after midnight, because the care becomes much less in the ICUs. I hope the situation is better in Oman. Finally, the family approach is our business, the coordinators and us, and I'm personally involved in the family approach because I'm, I'm a figure, I'm an old man. When I talk to the family, they trust me, and I'm a local person, I'm a Kuwaiti, so it's easier to convince them than if somebody comes from other nationalities and try to convince them. And finally, when we get the consent, we start doing our work so that we can do the retrieval and we can allocate the organs, and then we choose our patients who will be for transplantation, and then finally retrieval and transplantation. So this is the process all over the world. You have to take them one by one, study them, train your coordinators for them, and follow them. This is when we meet the families. Of course, we have our coordinators who speak different languages according to the nationality of the family. Sometimes, the family are not there. This is a family, only recently, I think a couple of months ago, family were in India, and I asked them if you can be kind enough to give me a picture of the family, and they kindly did that. They are all sad because they lost they lost their father, and these are the children who are really very sad. We could see them through through social networking. There are various programs like even WhatsApp that you can communicate with them. They can see you, you can see them. It's much better than a phone call because they don't see you. They have to see you. They have to interact with you. They have to see how you approach them. And you have to be really sympathetic with them when you talk to them, and then try to convince them for organ donation. Sometimes the embassy staff will be also involved. This is a case from Bhutan. And I was talking to the uncle of the young lady who had a brain death in Kuwait. He was a monk in Bhutan, and I explained to him, and he was kind enough to agree. And we had Bhutan embassy people who were there, and finally we got the consent and we took the organs from this young lady. Of course, sometimes you get refusal, either they are not accepting brain death. This happens a lot with most Arabs and Muslims. The concept of brain death is not well understood. Sometimes there's denial, no, he's not dead, his heart is beating. Sometimes there's pride, no, we don't want to give organs, and so on. Religious factors. Some people say we need the body intact, don't remove anything, and this is a cultural thing. It is neither religion nor law, but it is a culture. Fear of mutilation, oh, you're going to cut him up, this is also there. Fear of gossip, people say, oh, you donated organs, you sold the organs, and so on. And some of them are not happy about medical management, and they are very angry. They will not accept donating at all because they are not happy about the management of the case. Sometimes they are, most of the time they are wrong, they have wrong information, but you have to accept that if they are not happy, they will not donate. Now we'll come to the incentives. This is an important issue. Without incentives, we wouldn't have an active program in Kuwait, as simple as that. So what incentives? And is it practiced only in Kuwait or many other places? Is it ethical? What about Istanbul Declaration? Okay, what about Istanbul Declaration? I was in the steering committee for Istanbul Declaration. I was there in Karachi in 2005. I was in Kuwait when they had a meeting of WHO in 2006 with people from the steering committee of the Istanbul Declaration. And then we had a meeting in Dubai in 2007. And finally, 2008, I was there sitting here in Istanbul Declaration. And we discussed, this was under the umbrella of the TTS and the ISN. And finally, Istanbul Declaration came. I was also a member of the DICG with the Declaration of Istanbul Custodian Group. I was the co-chair of the Patient Affairs Committee. We're following up all cases of breaches of Istanbul Declaration in different parts of the world. We even visited Kuwait Minister of Health, Dr. Hilal Sayer, with Francis Den Monaco, who became the president of TTS. and we talked to him about unrelated donation. We visited Egyptian Minister of Health with Professor Haberal from Turkey. He's the head of the Turkish Transplantation Society, and he established the MESOT, and of course with Delmonico and Faisal Shaheen. And we talked to him about what is happening in Egypt, unrelated donation, people coming from the Gulf and receiving kidneys from Egyptians. So incentives. First of all, incentives are always there. I can't see any organ procurement without certain incentives. Often they are not admitted. They can be of monetary value, or could be other expenses like health expenses, like ICU, cost of ICU treatment. Nobody will take cost of ICU treatment from the family of deceased, because the deceased were kept in the ICU because of organ procurement. So it is unfair to take money from them for looking after them. That is some sort of incentives, because you say, okay, if you become an organ donor, we don't take expenses. This is an incentive. It is not cash, but it is indirect cash. Sometimes the incentives are non-monetary, and I will talk about it. Now, by the way, compensation is allowed by Istanbul Declaration and ethic committees all over the world. What is compensation? You compensate them for the loss of an organ, you compensate them. I think I've only got 5 minutes to go. You compensate them for loss of work, you compensate them for travel, and so on. And finally, of course, removing disincentives. And this is again by providing compensation. What sort of non-monetary compensation you can give? In some countries, in Saudi Arabia, they give a medal or certificate. It's great. This is non-monetary. They feel proud, the family, that they are given a model, and this is sometimes the model is by high authorities. In Iran, they give priority for medical services. So if you need a cataract surgery, you have to wait 2 or 3 years. You can get it in 2 or 3 weeks. So donor families get priority for medical services. This is not a monetary, you are not paying the money, but you are providing certain services. Honorable burial in Iran as well. They have a special graveyards for martyrs, and anybody who donate organs after death is considered to be a martyr, and they bury him in the martyr's graveyard. This is an honor for Iranians, and many donate encouraged by this sort of incentive. I think, officials should pay respect to the donor families so that they feel they are really respected because of their donation. You should publicize the heroic act. They shouldn't feel ashamed. They should feel that they are doing something heroic. And every donation should be publicized so that people get encouraged by this publicity. And, why shouldn't we provide some job opportunity for somebody working in Oman or in Kuwait? The person who was sending money to the family died. Why can't you bring one of his children or his brothers to work and give him a job opportunity so that he can continue supporting the family? You are not paying him, he's working and getting the paid. And in Qatar, they bring the whole, bring many members of the family of the deceased from abroad, from India, from Bangladesh. They pay for their tickets, they put them in hotels, and then they approach them for organ donation. They take them to the ICU, they explain to them about brain death, and they approach. And most of them will agree, because you are really honoring them, you are spending money in bringing them, caring for them. And sometimes they donate, maybe they will not donate. Now, monetary, as I said, hospital bills, burial cost, discounted travel provided in Saudi Arabia, life insurance to families being talked about in the West a lot. Repatriate cadaver, we do in Kuwait. We send the body on the expense of the Minister of Health. Paying dia, blood money. So if you lose a kidney in an accident, you are paid a dia. You can pay dia for taking organs from deceased or from living. We also provide family support by government recipients. Let me give you an example. This is Mr. Ibrahim. He lives in Sierra Leone. And he's an English teacher, so I could speak to him in English. And he's a very poor man, you can see that. He was so poor. He sent his wife to work in Kuwait as a housemaid. She died, brain death, and we approached him. I talked to him over the phone. I said, this is the situation. your wife is unfortunately dead, we can send the body on the Ministry of Health expense, and we can also provide an honorarium to the family in return for organ donation. And we told them these organs are going to be given free to all patients who are living in Kuwait. We are not selling or buying organs. We are honoring the family. And after discussing with his relatives, he agreed. So we sent him a consent form. I told him, sign the consent and send a photo. So he took a photo of himself instead of sending a photo of the consent form. Anyway, this is how I got the picture. I don't ask for pictures of our donor families, but it shows such poverty. What is wrong in helping such a man? He's really, he's really poor. He needs some help. What is wrong in helping them with small amount of money, which will help them for a while until they can help themselves? I think this is a great act. And we have in Islam our own ethics. وَمَا جَزَاءُ الْإِحْسَانِ إِلَّا الْإِحْسَانِ. So when you do something good for somebody, he gives you a return good act. Like, Professor Dar say, always say, Dr. Abdullah Dar, Professor Dar, it is rewarded gifting. He's giving a gift of life. You cannot put a price for organs. They are priceless. They are worth millions or even more. But to give them some sort of help, if they are really in need of help, I think this is a great act. Sometimes when the family says no, I feel more sorry for the family than for our patients, because our patients will get another chance. The donor family might not get another chance. So Western ethics may not necessarily apply for our situation. So through this program, over the years until the end of last year, we have received 1,050 organs and tissues and given them to patients from 321 donors who received help from Kuwait. Most of them were kidneys, but they were livers, heart, lungs, and pancreas. Now, the waiting list is becoming shorter and shorter, and the waiting time depends on the blood group. For blood group A and B, it is around 1.5 years. For AB, even less, but O, we have a large number. And then because of we don't have lung transplant or heart transplant, we have organ sharing with Kuwait, with Kingdom of Saudi Arabia. This was Sir Majdi Yaqub, who came in 1996, and he procured lungs, heart, and liver and took it to Saudi Arabia. He was visiting Saudi Arabia when we had the case, and they took the organs, and we started in 96 the organ sharing, and since till now we have shared, we have given them more than 409 organs, livers, hearts, lungs, even kidneys. Sometimes they need a kidney for combined liver and the kidney, we give them kidneys. Sometimes our team refuse to take the kidneys and they accept them, and so on. Recently, we started organ sharing with United Arab Emirates. We had 3 cases so far over the last 6 weeks, and this program is developing really fast. So we hope to have organ sharing not only with these 2 countries, but with other countries. I hope one day we can have organ sharing with Oman and also with Qatar. What are the future? Improve organ procurement from deceased, improve donor management, explore the possibility of DCD in Kuwait, something we haven't explored yet, organ sharing with other Gulf countries, reactivate liver and pancreas transplantation in Kuwait, hopefully next year, in the coming few months, and start in heart lung transplantation. I think I've taken a little bit over my time. Thank you very much for listening, and I'll be very happy to answer your questions.
Thank you so much, Dr. Mustafa. It was a comprehensive lecture, and we really can see the difference in early 90s and now in 2020, the number of deceased donors in Kuwait, and how you progress fast actually comparing to 90s. So now we'll open the panel for discussions. So please, anybody has a question, he can raise his hand directly. We will open the microphone for him.
Hello?
Yes, Salah, yeah, you can start, Salah.
Yeah. Thank you very much, Dr. Mustafa, really, for giving an insight about the disease donor program in Kuwait. I think it was a hard work and it takes years to reach to the level. We hope we are going to reach the same. Just have two questions regarding the death certificate. Really, you give us a very important point that the death certificate should be issued once the brain death diagnosis, not at the time of the procurement. However, does it apply to patients who are refused donation? So do you issue this certificate also for those patients? Because it will be like a bias since they are donating, you give them this certificate at the time of brain death, or people who refuse donation, if you give them death certificate at the same time, like treating donors or not?
No.
Yeah,
this is a good question. No, we don't. The whole thing is to sign the death certificate before is to cover ourselves. Because as I said, one case, we took the organs and we took even consent from the family. And then one member of the family, he looked at the death certificate and the timing of the organ retrieval. And he said, this means that he was alive when he took the organs and he died because of retrieval. So he raised the case to the court in Kuwait, but of course he didn't gain anywhere. I mean, we told them the situation. So since then, a ministry decree said that when we are taking organs, when we have a consent, the death certificate should be before retrieval. Now, do we do it at the time of brain death documentation? If the brain death documentation was yesterday and retrieval is tomorrow, we usually don't issue it on the day of brain death. We just issue it before taking him for retrieval. So at least we cover ourselves legally to say that he was dead before going to theater. So the whole idea is just for when we have a consent, when we are taking the organ to theater, just to cover ourselves legally.
Yeah. The second question regarding the incentive, it's really very important. I think it is, the question is, do you offer the incentive at the beginning or after, asking the family for the consent for donation and they accept it, then you offer it later? Because it's very important. If you offer it at the beginning, so they have a motive to agree, to donate their relatives' organs. But if you offer it at the end, once they agree, then it is, ethically more acceptable than offering it at the beginning.
We follow the first. So look, I do the approach in majority of the cases. So what I do, I start by saying, first of all, giving them my sympathy, my condolences to the family, of course, if they are available or over the phone or whatever. And then I told them, what do they understand about the condition of their loved one? I make sure they understand brain death. And brain death has been explained by the intensivist before and also by our coordinators. They explain brain death, they show them the images of the SPECT scan and so on. Without them accepting brain death, we cannot even approach for organ donation. So once they understand that, we said that, okay, we have a program since 1996 to help the families who are in need. We send the body and we give a help of this much to the family, but in return for this help, we also need a help which is even greater than the help of the ministry from the family. I make them to feel that they are doing something, they are doing something for us, not we are doing something for them. They are doing something great for us. And we tell them, you are saving lives and the deceased will be, receiving a reward in the hereafter because of this, life-saving donation. And we tell them, if you have something valuable, you don't bury it. If you bury it, they would be wasted. So we try to really convince them. If you make them feel that you are paying them for organs, I would say 99% they will say no, even if they are very poor. They should really understand we are not paying for organs, we are helping the family. We have had, Kuwaiti donors, they don't need the money, but we tell them we have this, ministerial decree to help, to give a donation to the family of donors. And sometimes they take it and give it to the poor. They take it and give it to build something, like a mosque or something. So it is offered together with the asking for help for donation. So it's coming in one package. It is not separate. If we separate it, I think the number of consent will decrease.
Okay.
Is it an incentive? Is it an incentive? Yes. And I admit it is an incentive. It is a powerful incentive, and without it, we wouldn't be successful. But as I said, there are other ways of doing it, like, you know, the DIA or KADA. There are other ways to make it more palatable to our societies and also to abroad, to other communities.
Yeah, last question. Thank you very much, Dr. Mustafa. I'm an HPV and liver transplant surgeon. You said the last, your last slide, which is future perspectives. I see one of the points there, reactivating liver transplant program. So can you elaborate on this a little bit?
Yes, I mean, the program started about, I think, 4 years ago, and up to now, 11 liver transplants were performed in Kuwait by a Kuwaiti team with help from King's College. I understand you get also help from an ex-King's College surgeon, which is Muhammad Roller. So we get, you know, an Arab who's working in King's College, Dr. Wael Jassim. He's originally Syrian, and he comes with an intensivist, but our guys are also involved, and they do the transplant and the retrieval. So the program came to a stop because the hospital they were working on, which is called Mustafa Jaber, has become a COVID hospital. I hope that soon they can return back to their activity. So we are really starting our program in the very near future, maybe in the next couple of months.
Okay, thank you so much, Dr. Mustafa and Dr. Salah as well. Now, Dr. Adel Kharousi, he has a question.
Of course, wonderful presentation. First of all, I'm Dr. Adel, the head of intensive care unit of Khawla Hospital. I'm really interested about the program and to be successful as you are applied in Kuwait. My question is that I really want to understand about to start. I know it's difficult. You said about there is a transplant center. I mean, what do you mean by transplant center? Is it separated institute? Is it belong to MOH? And if we are going to start a program, we are in the hospital, and each hospital has its own policy and protocol and guideline. Who is formulating these guidelines? Are we taking it from that center? If you are formulating a center and it will be separated from all the Ministry of Health, it's just going to be with own budget, because you said there is a courses and training. Who will train the ICU staff or the other staff? I mean, these these points have to be clarified, because you have already published a successful program. We are just started. The regulation, the laws, still is in the process. This is what I hear from Dr. Ahmed Al-Mousawi. The other questions is regarding the when you start a program, which successful organ to start with? I mean, what is it the kidney to be as the priorities, or you how you decide? And I mean, there's supposed to be that, as you said, the center has to decide for this organ transplantation, and it has to be organized very well, and the team has to be separated. How they approach the other surgeons to the other hospital, because I think if there is different organ transplants, mean different specialty, different surgeons will be located in different hospitals. Transportation of these as well, these organs has to be regulated. So still, what I know, still we don't have separate team. We are working individually, each hospital. We just know about the program maybe 1 month back. So I know it before, definitely. But to be like professional and well organized as in your country, I think, yeah, we have to establish but it needs a lot of work and a lot of cooperation, coordination. Especially, I like the way that there is a center, there is a headquarter, and we have to follow. So maybe you can explain it.
Okay. First of all, one of our big mistakes is to have separate centers for this. In Kuwait, rich families, they come and donate money to establish a center in the name of loved one. Our center is called Hamid Al-Isa Organ Transplant Center, which was built in the 80s. This was a donation from Al-Isa family. Al-Isa, Hamid Al-Isa, he was a kidney transplant patient himself. In the, I think it was in the 60s or 70s, he had a transplant in Germany, and then he developed pneumonia and died. Rich family, they are the agents for Kellogg's cornflakes. You can imagine they are very rich, you know. So they donated the money, and the ministry accepts the donation. They make a center in their name, but the center is attached to a hospital which doesn't have all the specialties. It is a hospital basically for neurology, neurosurgery, and pediatric surgery. So we don't have cardiology, we don't have respiratory, you know. So we are working in a very poor situation. It is best to have the transplant activity or department or unit in a general hospital where you have all the specialties around you. That's why the liver program didn't come to our center. They established it in Mustashfa Jabir, which is one of the new hospitals, the huge complex, and they have all the specialties. We are asking the ministry to transfer us from our center to Jabir, so we'll be under one umbrella with the liver team. In fact, all transplants should be in general hospitals. Liver, pancreas, and kidney should be under one umbrella, and cardiac and lung should be another umbrella, but maybe all within the same hospital or in two different hospitals. So this is my advice to you. Don't have your own transplant center. It is not good. The other thing is that the budget, you know, we don't have a budget for our program. The ministry is paying for the doctors, for the nurses, for the equipment, for everything. And when we need coordinators, the ministry is paying for them. So we don't have a special budget. We use the budget which is available for all hospitals to work. The protocols we write and the ministry approves. The regulations, again, we write it together with the ministry and we get it through the undersecretary or through the ministerial decrees. Transportation is easy in Kuwait, it's a small country. So a car is enough to go from one hospital to in one extreme location of the country to the other. Half an hour is only. With the new motorways, you don't need more than half an hour. So it's very easy, but I think a country like Oman, like Saudi Arabia, huge countries, big countries, they need better ways of transportation. You need helicopters, you need evacuation planes. When the Saudis come to get organs from Kuwait, they come through special evacuation planes. And it is owned by the government. The Emirate people, they don't have evacuation planes by the government, so they pay special or private companies pay money for these to provide them with an aeroplane for the team to come and take the organs and go back. Did I cover everything? What is important first, I think kidney is the most, if you want to start, you should establish kidney. And I think you have already have a kidney transplantation. For deceased donation, you can establish everything. If you cannot use the organ, give it to the neighboring countries, give it to the Emirates, give it to Saudi Arabia, and so on. So I think you shouldn't throw any organ away. If you have a consent for the donation and the family doesn't say, please do not take the heart, then you can take everything, or do not take the eyes, or do not take the corneas, then you can take organs and tissues and use them for the people, whether in Oman or outside Oman.
Okay. Yeah, wonderful. What about the in-house team? You said there is a coordinator. Does it mean there is each a hospital, tertiary hospital with ICU, there is a localized team, you mean, or specialized?
Yeah, very good question again. So far, I had a shortage of coordinators, but now recently, since I have around 7 coordinators, From next week, from January, I'm going to put one coordinator in each hospital. So he will look for, for any potential cases. He will follow up the cases. He will talk to the family about brain death, and he will help us in approaching the family. So this is going to happen in fact, beginning of next year. So far, we are all in the transplant center, where I meet them twice a week, and then they go by the car, they go around and see, and also, of course, intensivists and nurses sometimes refer cases, not sometimes, but most of the time they are cooperative and refer cases. But we need to really, the best idea is to have a coordinator in every hospital. This is what's happening in Europe and America. There are, coordinators, and there's a coordinator office in each hospital. That would be ideal. We don't have offices, but our coordinator will be based in the ICU. He will go around with the ICU people, and he will report to us any possible or potential cases.
Have you got any cases from the A&E, for example? If there's, for example, very bad head injury, a patient, for example, in the emergency department, can we target the emergency? Have you taken cases from the A&E?
You see, emergency, if they, most of them, if they are severe injuries, they will go to the ICU. And then we follow that from ICU. But if you are looking for disease, DCD, which is after circulatory death, then I think we should cover the ICU, the emergencies, so that we get cases from DCDs and so on. So far, we are only relying on brain death, but this is a future plan for us.
Yeah. Okay. Wonderful. Yeah. Well, you cover very well. Yeah. Thanks a lot.
Thank you, Dr. Adil, for your participation. Now we'll open the discussion for a question for Dr. Abdullah Al-Farai.
Yes. Thank you, Dr. Al-Mousawi, for being here. And I would like to thank the Oman Transplantation Society to organize such a presentation. I have just two questions. The first one, how do you see the progression of the Kuwaiti society acceptance of the disease donors over the last, I would say, 20 years? And yes. The second question, what's the percentage of Kuwaitis having the donor card right nowadays?
Okay. To answer your second question, so far we have about 15 or 16,000 people, Kuwaitis, who carry donor cards. The numbers are small. In Qatar, they started only a few years ago, and they have 350,000. So they are doing great. The reason is that they have a budget. The Qatari government are providing a budget, and they have in every mall, they have a booth, and they have nurses and doctors who are given extra money to sit in the booth and encourage people to take donor cards. Unfortunately, our society, we don't have any budget. The budget that we have is just covers our expenses. So we are using social media, and we made it easy for people to donate by just sending a message by WhatsApp to our society. And then we take the details, the name, telephone numbers, and we send them the card by post. So unfortunately, we are not as active as Qatar in this respect. Now, acceptance, what was your first question? Acceptance of the people. Yes, I think the more you become active with years, when people hear about organ donation, when the newspapers and media cover your activity, the more people will accept, because there will be interaction by the people. Some people will say, yeah, is it allowed, not allowed? And then religious people say it is allowed. And young people are easier to convince that this is something good. So interaction happens when you are, the more active you become. Even among hospital staff, when we first started, many hospital staff didn't accept it. And now they are all accepting it because it became a routine. Every couple of weeks we have a case, every couple of weeks. And every week we have 1 or 2 cases. Of course, some of them will not accept donation, but this is happening every few days. So people got used to it. I think when you start, initially you find people will not accept it, neither the ICU staff nor the public. But gradually, as you go along, it will be accepted. I think in Oman, what you need to do to also, avoid our mistakes. We try to rely on, only ICU staff as coordinators. I think you should have, a number of coordinators, which are ex-nurses, so they are aware of the medical terms and so on. And they should be trained, and they should go to the ICUs, give talks to the ICU staff over Zoom or directly, face-to-face, and then you start. I think it takes some time, definitely. So don't think that you will get a large number of donors in the first year. It will take time, because our societies, they don't have the donation culture. The whole thing of brain death is very controversial still now, despite the fatwa, which we have since '86. But, religious leaders, sometimes they go backwards rather than forwards. And now many religious leaders, haram. I think you have to convince religious leaders, you have to convince the public through your activities.
Thank you, Dr. Mousawi.
You're welcome.
Thank you, Dr. Abdul Fara'i. We have a question from chat panel from Dr. Tawfiq Al-Lawati. Can you progress without a clear regulation on the details of the disease donor program, like the rights and the limits of the medical team, family, and brain dead, and the lawsuits and so on?
Can you repeat it? Can you progress?
Without a clear legalization on the details of the disease donor program.
No.
For example, the rights and the limits of the medical team.
The rights
and limit of medical team, yeah.
What do you mean the rights of the medical team? If the medical team is against donation?
No, I mean here it means that, for example, have we put any standardization, for example, for the medical team who participate, for example, in the retrieval? So, have you put any legalization for them?
We have Kuwait Transplant law, which allows taking organs from deceased, provided an independent committee decides on death. We are not involved. We're not involved in documenting brain death. But once brain death is documented by the committee, usually the intensivist and the neurologist will come and document brain death. A third, I think we should have only two. Okay. You don't need to have three. So only the intensivist and the neurologist can declare brain death. In Kuwait, we have a third person, usually it's a treating doctor. Any doctor can sign. And then we have a documentation. Once we have a documentation, we arrange for retrieval. Our retrieval team, they are of course expert in retrieval. They have been trained, and most of them they've been trained outside the country, and they know how to retrieve kidneys, livers, and so on. So we are doing everything according to the law and the regulation. There's no problem.
Okay. Sure.
As long as you have your protocols, your regulations, nobody will object. We haven't had any objection from any of our medical team in Kuwait.
Okay. Sure. So we have another question from Dr. Abdul Latif Raisi. Can we open the microphone for Dr. Abdul Latif? Yeah, Dr. Abdul Latif.
Hello, good evening, Dr. Mustafa and the coordinator. Your information were very, very informative. Really, I enjoyed listening to it. I'm a corneal surgeon. I did so many corneal transplants, but now since we are in the process of starting our organ transplant program, and we would like to have, as you recommended, a common center. So what's your experience in relation to the activities in Kuwait in the corneal transplantation? And do you have an eye bank there, and how was the relation between the organ transplantation and the eye transplantation? I say that because we would like, in the process of establishing such a center, to reduce the expenses so that the eye bank will be integrated, or the organ transplant activities will be integrated in the same area and same eye bank, because I know that I have experience in eye banks, I work in eye banks, but because my experience goes in King Khalid Eye Specialty Hospital in Riyadh, where I started my training there. So which hospital, it is exclusively eye hospital. doesn't have a relation between other organs. So how would be the relation between the eye and the organ coordination?
Thank you. First of all, let me just reiterate, you don't need a center for transplantation. Please make it in a general hospital. Regarding the eye, our transplant center is next door to an eye center, مركز البحر للعيون. So initially we used to, whenever we have a donor, we used to ask one of the ophthalmologists to come with us to retrieve the eye. And then one of our registrars, surgical registrars, she's a lady from Egypt, and she was helping in retrieval. And she learned the technique of removing the corneas. And now for the last many years, she's doing it on her own. We don't even call the ophthalmologist. We just take the solutions for keeping the corneas and the, when we retrieve. And our registrar, she removes the corneas either during or after the organ retrieval. It only takes few minutes. And they are very grateful for our corneas because they import corneas from outside. And the corneas we give them are usually much clearer because they are fresh, much clearer than the corneas that they used to import from Sri Lanka and now from Iran. But the corneas which are retrieved locally are much better and much clearer than corneas from abroad. So all you need is just a container with a solution, put the corneas and give it to the eye center. Very simple.
No,
either ophthalmologist can come and do it, or one of the transplant team.
I know that. Excuse me. I know the process of retrieval and all these things, but I say we are in the process of establishing an eye bank. I know that eye bank is not Kuwait doesn't exist in eye bank. I don't know whether you can give us an idea as to make our center as easier to establish in terms of reducing the expenses, so that the eye bank will incorporate the other tissue banks which are needed, but not organs. Organs usually are not kept, but the eye bank can keep corneal tissue for weeks and months.
Sure.
So I don't know whether. I'm just asking that the relationship in the area itself, in the bank itself, between the organ and the eye transplantation processes.
Yeah, the only relationship that we retrieve the corneas and give it to them. I'm not the right person to answer this question. Should be an ophthalmologist in Kuwait. I don't know if they have an eye bank in Kuwait, but usually the corneas, when they take either from abroad or locally, they usually transplant them to patients within a few days. They don't keep them for ages, because the longer you keep them, I think the quality of the cornea will not be the same. This is
that's true. That's true, doctor, because we did here corneal transplantation since 1996, and I myself transplanted about 88, 87 corneas here in another hospital, but it was interrupted by different reasons. Now we want to establish an eye bank. So thank you very much. You answered the question almost. Thank you very much.
Yeah, welcome.
Thank you, Dr. Ablatif. Now we have a question in the chat from Isa from UAE. He said, great experience and fascinating work down the memory line. The question, what would it be to take to increase awareness of a disease organ donation in GCC citizen, especially that the most recipients are from these countries, respectively?
Yeah, it's a good question, So a lot of public education is required, and that is, as I said, is very costly. It should be undertaken by governments, but after all, it pays for itself, because when you get enough organs to become self-sufficient or approach self-sufficiency, then I think the governments of the Gulf areas will save a lot of money, because a lot of patients are sent abroad for transplantation. And we have some data from Kuwait that some of the liver transplant patients who traveled from Kuwait to the United States cost the government around $2 million for some of the patients, because they have to go, they stay for a year or 2 or 3 years waiting for an organ, and the government is spending money on the patient, his follow-up, his treatment, everything until he gets a liver, and also paying for his companion. And eventually, when they get a transplant, the cost of a liver transplant is around $500,000 nowadays. So it's a lot of money. And I think if we can really encourage organ procurement, encourage organ donation in our Gulf area, then the ministry can save a lot of money. It needs basically involving religious leaders, because majority of the people will ask, what about religion? Is it allowed? What about brain death? Is it real death? These are the questions that we need to answer, and we need really involvement of the religious, of the religious affairs ministries and so on. Let me give you an example of Iran. How did Iran become so successful that it's #1 in the Middle East? I think because religious leaders, the government, the media are all combining together in encouraging and making this program not a limited program for the whole nation. It's a national program. And they make interviews with donor families, they make them heroes in the media, and that encourages people. In Kuwait, when we approach Iranians, we fail. They don't donate. But I don't know, in Iran, they are donating right and left. And they are doing a good job because of the media, because of the interaction of everything, from media, from religious leaders, and so on. And they become very successful. I think this is a model that we should follow. And also they are giving incentives which are not monetary incentives. And I think this is great. For example, giving them priority medical treatment and so on. This is something which is really, nice and can be propagated in other, countries.
Can I ask Dr. Waris?
Yeah, Dr. Ahmed now.
Thank you very much. Thank you, Dr. Mustafa. We are very glad that you are with us today and you gave this very comprehensive lecture. I have two questions. One for the coordinator, the transplant coordinator. Is he like a full-time? And if he's a full-time, is he doing other job because this brain is
I can't hear
to
you.
the family and so on?
Yeah, I just hear that. Is he a full-time? Yes, he's full-time.
Yeah, is he a full-time because this donor, it comes only once in a while. So is he doing other job, or is he like part of the?
I can't hear you. I think the internet connection is not that. I got your question. I think first of all, it is not once in a while. In Kuwait, it is a daily event. So we have daily referrals, daily potential cases that we follow, because in Kuwait, we have around 700, 800 people die in the ICUs every year. And out of these, at least 150 are potential donors. So we have donors every day, and we follow donors every day. And these are full-time coordinators. They follow the cases, they approach, they go for retrieval, they do everything. In addition, they keep the statistics, I mean, all the statistics related to donation. They go and check the number of admissions, number of deaths, how many admissions, CVAs, how many admissions, car accidents in different ICUs. They keep the statistics. So they are quite busy. And the other thing is that they are keeping the waiting list. All the waiting list is under the hands of the coordinators. So we have a weekly meeting attended by surgeons, nephrologists, and the transplant coordinators. All the cases who are for transplantation are discussed. If the person doesn't have a living donor, then he will go to the coordinators. They will take all the data. They get the clearance by medical and surgical, and they talk to they bring the patients. There is patient education by the coordinators, telling them about transplantation, about the waiting list. Where is your position in the waiting list? The points that you get on the waiting list, for example, children are given more points than adults. If you have been in dialysis for 3 years, you get more points than patient who's been in dialysis for 3 months. So all these things are explained to the patients, and also they talk to the living donors. They talk to the patients who are going for transplant. So they have duties regarding the patients, regarding the living donors and deceased donors. So they are really busy coordinators. We have 7, but we could do with more.
So they are based in the hospital?
They are based with me in the transplant center, but they are always whizzing around to other ICUs. They are never stationed. Only twice a week they attend a meeting with me, but the rest of the week they are busy in other hospitals or busy, dealing with patients, with their relatives, with the donors, and with the donor families, and they follow up the donor families afterwards, and so on. So they are really busy,
And
yes.
Okay, sorry, but this background, all of them nurses?
So far, all of the nurses, but in many countries they have social workers. In Iran, they have psychologists. In Kuwait, they're all nurses. Yes.
Okay. My second question: what is the regulation if non-Kuwaiti want to donate to a Kuwaiti, like living, in Kuwait, living?
Yes, any unrelated in Kuwait, they have to go through an independent ethics committee. This committee doesn't have transplant physician or surgeons. They are meeting in a different hospital, which is Jahr Hospital. This is at the end of Kuwait, far away from our center. There's a meeting once a month or once every 2 months. They meet the donors and try to establish what is the relationship between the donor and the patient. If there is big suspicion that there might be selling or buying, then they will not accept the donor. So the donor has to establish his emotional relationship to the recipient. For example, if they were close friends or they were schoolmates, or there's some sort of connection between them. Is that always works and they don't take money? Well, my answer is no. I think the majority are taking money, unfortunately.
Thank you very much. Dr. Ward, I think there is one in chat, one question.
Yeah, so there is one question from the chat. What do you think about pair living kidney transplant in Gulf countries? Is it possible? And is this will expand our donor pool?
Yes. I think this is an important question. Paired exchange is now really spreading all over the world. People have stopped doing desensitization for their sensitized patient. They prefer paired kidney exchange. It is really catching, and it is really spreading in North America and Europe. In our area, I think there has a good program in Saudi Arabia. They have paired kidney exchange. In Emirates, they started. The good thing is that the software that we are using in Kuwait is by somebody's what is his name? I forgot his name. Anyway, the software is by an American doctor who is given the same software to the Arab Emirates and to us and to parts in Saudi Arabia. So Saudi Arabia, they have two different softwares. Dammam is different from Riyadh. Now they are trying to make it one system, and not only for Saudi Arabia, but also for the whole of Gulf. And I think Oman should have the same software. I can send you the name of the person, Mike Reed. And he can provide you the software free of charge. And he can do the exchange between all the Gulf countries. Because in Kuwait, if you have a small community, it's difficult to do a paired exchange. But if you share with United Arab Emirates, with Saudi Arabia, with Oman, and also the same program is being used in India. And Emirates now are thinking of sharing with India. So you can have Indian patients giving to Emirati patients and vice versa. So I think if we can expand the pool of paired kidney exchange, we can help our patients and we can get many more donors, especially for sensitized patients, because we have so many of them. And unfortunately, they wait for many years without getting a suitable donor. You should unmute yourself. You are muted.
Sorry, I mute myself, sorry. So you mentioned in your presentation that you do round in the ICU for the detection of the brain death. I mean, whose rule is that actually? Is who's the intensivist group or whom exactly? Because the surgeon, the transplant surgeon cannot do that, I suppose, I mean.
No, it's the coordinators. They do rounds. And in the ICU, sometimes they do round with the doctors. The EC, all the ICU knows what we are doing. They are supporting us. And when the coordinator goes, they got used to them. Initially, they were telling them, we don't have donors. Why are you coming? But now, because they get on a daily basis, they get used to them. They become part of their team. And once we have a coordinator there all the time, then he will be there all the time. and he will do rounds with the doctors. He will see all the cases and report to us any potential case. So in Kuwait, we have been lucky that we haven't missed a single case over the last few years. Every case has been we know about it and has been reported. This is something that should make sure that it happens in Oman.
It's very good way actually not to miss a donor and for early detection as well of brain death.
We tell them even unlikely donor, please over-report rather than under-report. I said even if somebody comes with CVA and he's walking, he's dancing, please report to me because he might deteriorate and might go in brain death. So every case, please over-report rather than under-report.
Okay. Thank you. The other question you mentioned about the reason of refusal. So a lot of people, they refuse actually for donation. But among, for example, expatriate and Kuwaiti, I mean, the rate of refusal among Kuwaiti are more or almost equal? Much higher in Kuwait. Kuwaitis, they don't donate, unfortunately. We've had a few Kuwaitis, about 8 families who donated. And some of them donated the organs of their very small children who drowned or fell from height and so on. But Kuwaitis are very difficult. Not only Kuwaitis, all Arabs are difficult. All Arabs are difficult. Most of our donors are from Southeast Asia, unfortunately. I don't know why. They speak that, you know, Islam, helping others, but unfortunately this is not happening, you know, because they don't accept brain death. They are always fearful that it might be haram. This is what is bothering them. But if you find, even among Indians, the Muslims donate less than the Hindus. I mean, this is happening as well. The Christians donate less than Hindus. Yeah, exactly. So you have to face the different cultures and different. Even I think we need more awareness among our especially awareness created by religious leaders. Unfortunately, religious leaders are divided, even about brain death. Some of them say brain death is death, others say it's not death. Some of them say it is halal to donate, some of them it is haram. So I think we need a consensus among religious leaders before we can approach the public, because sometimes once I approached a Kuwaiti and he said okay, and even our deceased has a donor card and we are ready to donate, and then he called me back and said I called the religious leader and said no, it is haram. They retracted their agreement. I think they need to speak up. This is a major problem. Religious leaders, they should agree actually in a statement. So we can pass the message directly to our public. It would be very nice to have a religious leader attending the approach to the family. This helps. If you are approaching Muslims, for example, to have a religious leader from the Muslims who is pro-donation and he tells them how good it is. Because I tell them the last chance for anybody to do any good deed in this world is the moment of death. Exactly. This is the last minute you can do something good. And I tell them what is better than when you go in the hereafter. They ask you, what have you done in your life? I saved 3 people from death. Go to heaven, because there's no greater. There's nothing greater than saving a life. This is a great message. I don't know why the religious leaders, they don't convey it to the people. I think, for example, in Oman, actually, we agreed actually on this, and even we organize some sort of educational lecture for public for organ donations. And it's, I mean, for us, it's clear, it's halal, and it's considered to be like sadaqah jariyah. So this is among all religious leaders, or only some of them? Well, هو مجمع الفقه الإسلامي, they agreed potentially, and our religious leader actually here in Oman, they agreed as well. I mean, they follow whatever in مجمع الفقه الإسلامي. طبعا there will be a few exceptions outside Oman, I mean, in other Gulf countries maybe. But overall here in Oman, our religious leader actually has agreed. That's why you're lucky. That's why we are concentrating a lot on public education. And at the same time, we are just preparing our environment for the deceased donor and our medical system. I think it was a very comprehensive and very wonderful lecture. Can I ask one question? Sure. What do you think about incentives to the families? I explained my view. Well,
can I answer this? Yes. There are 2 things. First of all, that Dr. Tawfiq, he asked very important question. Can you progress without clear legalization on the details of the disease donor program? I think we should do like what Dr. Mustafa said. We should have our own legalization or regulation because we have to protect ourselves as a procurement team and the Ministry of Health, of course. And we should also have to protect the donor family rights also. So we cannot do procurement without having a legalization first. Second thing, regarding the incentive, we have to be a little bit careful. We should have also regulation and laws. I'm telling you, this is actually a personal experience. When I had my second fellowship in India with Professor Rela Center, there we were doing like a disease donor to another hospital in the south of India. And after a week, I was reading the news in English in India. So every day I come in the morning and read the news. Then I said, oh, this is the hospital where we do procurement. And the family actually sued the hospital that the ICU doctors offered to them that, since your son is, he's brain dead, where, we're gonna, we should donate that organs for him, and we're gonna drop the ICU bill, which looks like a big, money. So these family went to the media and then they exposed the hospital and the team. I mean, we should have regulations and laws so we can avoid this kind of problems, because the impact in the society will be very big and it will be not good. It will, ruin the picture of the medical team and the Ministry of Health. So I think it is possible. We should follow also, as you said, that the Istanbul Declaration regarding organ trafficking, and we should make laws so kind of protect ourselves even in case of an incentive. What I think personally, we should offer incentive after the family that they agreed. So in this way, it looks like more ethical.
Okay. Good luck.
Yeah, the incentive, it's always a matter of debate. And well, in general, it is not that acceptable. But I think for our region, we should make it in a way that the community and the legal aspect should accept it as well. So it is not impossible, but we should be careful regarding the incentive, especially monetary incentives. And as far as it's not, away from the Istanbul Declaration, I don't think it's going to be an issue, but legalization has to be there just to protect the medical system and the rights of the donor of the family.
I think what is important is to be transparent. In Kuwait, we are very transparent. I go around the world. I've been to India and CAST. I've been to Turkey. I've been to the United States. I've been to Europe, and I talk about our system without covering anything. We said we pay money, and we believe it is something good. Yeah. We are not doing anything wrong. Nobody's making money out of it except who's benefiting? The patients and the donor families. And these are poor families that they need. In Europe, you have a social system which covers all these people. In our part of the world, some of the people, they don't have any income and they really need help. And I don't feel, ashamed or to pay these people. I think they deserve it. They deserve even more. We are paying them peanuts. We're giving them 3,000 Kuwaiti dinar, which is $10,000. This is nothing compared to the organs which are given. In India, they are making, the private hospitals. In India, as you know, 80% of the services are private, and the private hospitals are making thousands and tens, hundreds of thousands of dollars by transplanting these organs. And the poor donor families, they get nothing. They only probably get exemption from paying the bills. This is nothing. Yeah, I think they should be paid. And I tell them in congresses, what are you doing? I told them, what about donor families? Why don't you pay them? It's just against Istanbul Declaration. I said, is it with Istanbul Declaration, you take from the poor and give it to the rich? Because only the rich people can afford transplantation in India because they are in private hospitals. Do you think you are doing a service for them? Taking from the poor and give it to the rich?
Absolutely agree. I think Dr. Mustafa, in the coming Congress or in the Transplantation Society is better. We raise this issue And because the rules are different for our region to implement these rules, it might be beneficial for us. And we are not, I mean, we are not giving money for the sake of money. We are just helping the other the family of the donors.
And they deserve the help.
Exactly.
They really deserve the help. They deserve it more than our patients.
Yeah. And what we are taking is much expensive, actually. The organs are so expensive comparing to the money or whatever incentives we are giving.
I tell them when I talk to them, I said, look, this money is peanuts compared to your donation. You are doing a favor for us, not we are doing a favor for you, because these organs are extremely valuable. It is more valuable than diamonds and gold and everything. If you have something, a diamond, do you bury it with yourself when you die? You don't. You give it to the people who need it. So these are more valuable than diamonds. You are doing us a favor. So they really feel they're doing something good, and that's why they donate.
Yeah. So thank you so much, Dr. Mustafa Al-Mousawi. It was a wonderful and comprehensive lecture. I think we can even see we can start even the cooperation between Kuwait Transplantation Society or the National Program Center there and our national program here. And inshallah, we're going to invite you as well for the next series of lectures to participate more. Thank you so much, and it was a pleasure to be with us.
Thank you, Dr. Al-Warith, and thank all of you for attending the talk. I was very pleased to give this talk, and I'm ready to cooperate in any way possible to help you establish your program.
Thank you. Thank you so much. Thank you. Thank you, everybody, for the attendance here. Really appreciated your attendance. Inshallah, soon we'll have the next series of lectures organized by the Oman Transplantation Society. Thank you so much, and see you soon.
شكرا دكتور، جزاك الله خير، ما قصرت، شكرا جزيلا.
حياك حبيبي، الله يسلمك ويبارك فيك.
احسنت ان شاء الله، شكرا جزيلا، ما قصرت. ان شاء الله يكون لنا لقاء، ان شاء الله تشرفنا هنا باذن الله.
باذن الله تعالى. يعطيك الف عافيه يا اخوي، مشكور، حياك الله.
احسنت، جزاك الله خير، تصبح على خير، احسنت.
في امان الله، مع السلامه.